Yeah, one of these didn't record properly last time. I apologize. I was going to send you something over, but I had such an unreliable signal. So, and we're at the right place, so you could save listening to me for 45 minutes. I could save listening to me for 45 minutes anytime. Nevertheless, I'm going to try to get through as many of the bones as possible, having done a fair amount of the introductory work last time. It follows these PowerPoints. Hopefully I'll certainly get through A and B, and hopefully a little bit into C, maybe all of it. Sir, were they on Blackboard or not? Talk to me. Anybody? Is it A, not B and C? Then we'll do that right now. It won't take me a minute. Happy to do so. It's hard to remember. We were away in the wilds of West Virginia, and there was there was very little in the way of reliable internet. We were at a cell phone. It was delightful. You can't find us. We were happy to have that happen. I have to sign in. Maybe not. Voices. Are you ready? So 7A, you need, I did it probably twice, believe me. So we'll get it. So you need B and C coming up, all right? Upload. Just holler. Send me an email if I forgot something. I can do them at home just as well if there's something I forgot to add to you. I get it back kind of late tonight. Make it visible for you in a second. Did I put 6 on there or did I miss it? What we're doing in class today. Caramba. I'll get A. I don't think I have B handy here. Let's go see. I got A. We'll get B on there. I may actually be able to remember that. No guarantees. Feel free to email. It'll be novel. I'll finally get an email from somebody in this class. Other than ask me when the next test is. I hate that. Oh, we hate that. So do we. Here we go. All right, that's good. That's good. We're ready. We're starting. Enough for this top Flory. Okay. Hey, let's see what we got through. First things first. Okay, it's standard stuff. Cranium, I wrote down last time the 8 bones that were involved. We'll see those again, what they do. Facial bones, obvious framework for the face openings. Special senses, sight, taste, smell, air and food, secure teeth, etc., facial expression. Most are flat. The only one that moves, the mandible, temporomandibular joint, that's it. The joints are sutured because they have that sawtooth appearance. Of all the bones, when we get to the parietal bone, that's the one that is involved in all of the sutures. To some extent, they mimic 2 of the 3 body plans. This is not necessarily the top that goes on here, maybe it is. Kind of big again. This, you might remember, that sawtooth appearance, what you will see when we get to joints. These close. They're soft openings. And that allows the big passes for the vaginal delivery. And every so often there'll be some substantial dentistry, which alarms parents for that, but it's transient. Oh, I know. It's like, the real thing, it's really hard to parents about anything. And so we call them soft spots. one that closes the last is here. That's the one, it's a juncture of, this is called the frontal suture. Frontal plane, frontal suture. Coronal is another term, C-O-R-O-N-A-L. Again, coronal is like a crown. This is the sagittal plane, right and left, so the sagittal suture. What's unique about these is they all involve this bone that does not have any real anatomy other than that, called the parietal. Top, basically the top. So it joins together two parietal bones, right and left, form the sagittal suture, bounded by the frontal bone anteriorly and by the occipital bone posteriorly. Posteriorly, it resembles the letter lambda, so we call it the lambdoidal suture. Okay, so the Greek letter that's sort of upside down, Y, so to speak, in traditional Greek script, we'll call it suture, familiar with no doubt. And there is one more suture that is between the parietal bone, not really clear here, you'll see, called the temporal bone, called the squamous suture. In that context, squamous means shingle, and it's really not the same as the sort of sawtooth appearance. It's a little bit more of an overlap, like shingle. That's really kind of what the correlation squamous or squamous is. So that's the unique part, parietal bone involved in all the sutures. On the practical, you definitely have to know the name of the suture. I'm telling you everything that's on there. You should all do great. Please. So you can see the sutures are there, coronal, frontal, lambdoidal. There are the facial bones. Nice to see them. Okay, so inside, and I showed you it last time, the cranial vault has, basically it's made by the various lobes of the brain, interior, middle, and posterior. They call them fossae, or a fossa being the individual, put the E on the end, them collectively. The brain in there, cranial cavity, all well and good. Nothing really exciting about that till we're going to get to the holes today. That's important. Okay, you can see the lobes. This is frontal lobe for the anterior. You don't have to know this. I'm just clarifying it. This is, you can see there's a little, that's called the lateral sulcus. It's a divide. It doesn't go all the way through, but this is the temporal lobe, mostly for hearing. And then what makes the posterior lobe is this, is really like, it's really not, it's a very, very important area of the brain, the second largest, called the cerebellum. And really it's extraordinarily important and very, very interesting. And so that's a classic view that you can see here, this sort of side views, and you see those a lot. And then the other cavities, an ear cavity, nasal cavity, orbits. So these are important, and what we'll tie when we get to the next part after doing bone. I do muscle a little differently. When we finish with bone and whatever I do on muscle, and I clarify that for you, my least favorite area, I'm confessing, teaching muscles. So I'm going to give you the major muscles. I do not want to go crazy with all the muscles. I hate it. Not interesting. There's so much to cover. And thankfully, a lot of people work out and they know their pecs from their lats, from their traps and all that stuff. So it makes my life a little bit easier. I'll give you the major muscles in the group. I won't go crazy with the extremities. Depending on where you're going with your careers, depending on where you're going to be, they're going to reteach this. People going to PA school, the whole thing over again. You revisit anatomy and physiology, and it's all in a degree of detail. Medical school, they just up the ante with the degree of detail. So I'll try to give you the basics. It's my least favorite area to teach. See, I always found that you need to really show it. I mean, you could dissect a mammal. I don't get it from that muscles. And we're too small. And if you didn't, it's very, very pricey for cadaver dissections. Very, very pricey. It's not something you can routinely do. We'd have to pay to traffic you guys down to Pitt to have that if you wanted to take a look-see at that. And it's very expensive. I know what they were charging years ago. It's wild. It's crazy. It's just a side. On my early teaching career, 23 years ago, I was teaching A&P up at IUP. for non-major, for nursing students, for safety science students from their version of our health sciences. And it was a fun course to teach. I was doing the lab, somebody else was doing a lecture. And the majors actually had an anatomy class with a cadaver. And I got in touch with the professor who was teaching it, and I said, hey, is there any chance I could just have the students in and take a look at it, not touch it, just take a look at it, and they could see, and we could point to some stuff. If I let you do that, everybody could do that. I was new in my career. I wouldn't have occasionally say, isn't that the idea of education? But, that would be me. I was trying to get on full time there. So I didn't want to tell somebody, what the? And I found out from, interesting, he's a friend of Dr. Dress. If you didn't know Dr. Dress, winter undergraduate, one of his mentors, who was the department chair at the time, said, he's always like that. Kind of left his session. See that? And that's the kind of thing I think helps more with muscles to defend my indefensible position. But we will go over these foramina, canals, openings for what goes through when we do the cranial nerves. That's why you need to know. I mean, some are fairly easy, but others are not. Okay? I mean, when we get to the optic canal today, optic eye, optic nerve, gee, not hard. So this just gives you an idea of these openings, nothing big here. Cranium. So cranial bones, I wrote this out last time. Again, the ones that participate in the orbit, frontal. We found a little bit of some of these plastic models. Not enough, but what are you going to do? They're so small, and they get mangled. Somebody walks off, puts them in their pocket. Who the heck knows? Parietal bones just did. Occipital bone, frontal bone has very little anatomy. Occipital bone has a couple of important ones. Temporal, and after this, it gets very, very busy. Those last three. So the frontal bone. So as you can see what it's describing there fairly straightforwardly. Look at it from a skull perspective. Just look at the skull itself. Nothing to it. The upper margin of the orbit. This is, again, supraorbital ridge. Basically, eyebrows are. There's not a whole lot else. There may be a subtle indentation. It's got these domes. Basically, between your eyebrows. I always joke about my Jewish first sportsman. Unibrow. Or brow cake. Cro-Magnon. All your first boyfriends, your dad's son did. Didn't they? So there's not a whole lot else to it. So all you have to remember is the frontal bone participates in the orbit, superior portion of the orbit, the orbital margins. There with the supraorbital ridge, there's a foramen into it. Little nerves go through it. That's it. Parietal bones, nothing special. So I don't really see anything. Yeah, this is probably the version of it. The stupid plastic model is kind of like this. Designed to see the top of the margin small. We've got some of these that are much too small. Which brings us occipital. Then occipital bone. Occipital bone, these are roughly the same. Imagine this is the spinal cord. It sits. Sitting on a bone, we're going to look at shortly called the atlas. Remember atlas holding up the world. That's the first cervical vertebrae. And obviously that's the most distinctive of all landmarks, the foramen magnum. There's no bigger foramina in the skull than that. That's the foramen magnum. That's there. So that's really the significant piece of the anatomy. You look at this point. I had a mark a little bit, a marker from years ago. These are sets. Okay. Those facets are on there. So these particular facets, they articulate with what are called the superior facets on the set first cervical vertebra. And as you can see, basically it permits, because of the shape, when we get to joints, there's sort of a typical condyloid, sort of concave here, convex here. It allows motion a little bit side to side like that. That's the joint that's there. That's a significant piece of the anatomy as well. Here are a variety of ridges in the back of the nuchal. That's in the back of the neck, Nuchal, is the way to pronounce it. And they're always formed by attachments to muscles. The lump back here, we all have what's called the external tuberous. Again, muscles that you have, think of it this way. Not a whole lot of muscle here. It's very accessible. The vessels are there, trachea. Back here is a whole lot. So this is all muscles, ligaments, a very, very busy area, very, very thick, which tremendous amount of hold up on that head. It's easy to hit. Then on either side, you're going to see a couple of little openings that are there. So I'll show them to you. There's one on either side, they both go this way. The other one, I got another example, we go the same way. That's the hypoglossal canal. Hypoglossal means below your tongue, and indeed the hypoglossal nerve, which traverses the canal, happens to go to the undersurface of the tongue and allows you to do that. Stick out your tongue. See, I just stick out. He's stuck in his tongue to us because I'm trying to demonstrate. When you get to the teaching point, you tell somebody to stick out their tongue routinely. Go straight. Those who go straight say, don't fool around, just stick your tongue straight. I am. If they say they are, it's still diverting one side or the other. Because it was divert. It's got to be contralateral to divert at the same time. It's usually a more significant problem, lesion somewhere in and around the lower brainstem jangle. So that's something that's worth noting. That's really the important exit point. Other than the foramen magnum, and basically it's the bottom. The brainstem goes down. When the brainstem clears this area, it becomes the spinal cord. The anatomy changes relatively well. It's not like all of a sudden it makes a very rapid transition associated with it. And voila, that is your occipital bone. But are we done yet? No. We are not done yet. So if you look in the undersurface here, and this is a model, you see the blue and the red there for attachment. The traditional origin insertions. Okay. But we just call them attachments. But here, you can see sort of a gash-like opening here and here. That's the juncture point between the occipital and the temporal bone. You know the temporal bone, with one's the bump behind your ear, and that opening is the external acoustic. So because of that, this is a confluence area. So classically, I think they attributed more to the temporal bone, but I don't think they should. It is the jugular foramen. That's another important area. Not only does the jugular vein, one of the largest veins that you have, draining, and that's the term we use for vein, bringing blood back, part for reoxygenation, but a number of important cranial nerves pass through that structure. And it's cranial nerves 9, 10, and 11, 12 is hypoglossal. Easy way to learn is kind of how they go like that. So that's a really important area. When you see an opening for a vein, veins flatten out, so they look more like that. Arteries hold their shape. And if you look going forward or interiorly from that point, this is much, and most of these don't have a complete opening, directly ahead of it, and that's much more in the, barely put my, this should be all open. There's a circular opening directly anterior to this on the inferior surface here. That's called the carotid canal. Carotid is the artery. The only thing that goes through that is the artery. Typically, that's pretty much consistent. Veins tend to have a little more space, but the arteries are pretty distinctive. They penetrate some. So they on either side, and that's more temporal. So they're really important and they're easy to get confused. So you can always tell the jugular. Look at this way, maybe you see it this way. They don't have a carotid canal going through. It'll be over here. Jugular framing like that. That's part of it. What they do not have is we had a better temporal bone model than this thing. It's so small you can't really see the anatomy. I mean, I can see the anatomy, but I have to teach it to you. So I shall. Ugh. So frontal bone, not supraorbital margins, eyebrows. Rest not important. Here's the glabella. And you'll see a lot of these illustrations are very repetitive. You see the same one all the time. This actually is better for facial bones than cranial bones. You just be able to see the parietal bone, be able to see these margins that are there. This is the fossa itself, just to open. And again, it's very busy. We are going to get inside the bones that are the hardest. First the temporal, then the ethmoid, then the sphenoid. Those three deeper bones, particularly these two being deeper, ethmoid and sphenoid. The sphenoid is very unique structure. And what I do for the practical is I print these in color, as well as use models or or the bones themselves. So I have pipe cleaners and whatever. What does my wife call them? Not pipe cleaners. Something stems. They're like, she's a craft person. I forget what it's a modern term for us. We call them pipe cleaners. Pipe cleaners, little markers like this, Q-tips. I'll put like a little flag on it. Labeled A, B, C, or D. That's the way I do it. On the day we have that practical, I'm thinking 2 weeks. I will. What do you have in your schedules? Talk to me. On the 26th or the 3rd. When's Dr. Hillwood giving you a test? We'll do it the easy way. What? This next week. What about the weekend? What about the week of the 26th? Probably not?
Probably fine. Or I don't know.
Okay. Good. So it'll be the 22nd or the 29th. Want to make it the 29th? I'll talk to her and make sure she doesn't clobber you then too much. I can't guarantee she'll. You can try bribery. What?
29th.
You're voting for the 29th. We have the 29th. Is there a second for the 29th? It's like a vote. Robert's Rules of Orders. 29th. All in favor of the 29th signify motion passed. And we should be in Congress. We can actually get something done rather than those doofus politicians who are busy intellectually, forgive the term, masturbating. That was I hope that didn't offend anybody. Tell a story. I can tell if politicians lying, mouth is moving. I'm mild. My wife will go off right away. God bless her. All right. And we'll get into, we'll look at all these things, nice pictures. Parietal, all about the sutures. Pardon me. Coronal, sagittal, amboidal, squamous, or squamosal, who cares? Thank you. Occipital. Okay. Along the sutures, we don't count these as extra bones. You're going to find you have a lot of little extra bones. Sutural bones are common. It's just the sutures, it's almost like it's incomplete when it formed, and it looks like an extra piece of bone. It's there. They call it a sutural bone. We have, your kneecap is one of them, what are called sesamoid bones. And we commonly have the kneecap and 2 sesamoid bones under your big toe, under the head of the first metatarsal, which stabilize your big toe for walking. We have lots of extra of those too. So a lot of people have those. So again, those are more anomalies in the sense when we see things that we see a fair amount, it's not really abnormal. So it's not unusual to have that. Like I said, bone's interesting in that regard. There's that supranuchal NUCHL line. You have the protuberance sort of at the center of it. You have these other, there's other lines historically. Like I said, medical school anatomy, it's everything. Because they want you to know what caused what line. It's an exercise in memory that most of us forget. Boy, you're just going crazy here with this. You gotta stop pushing it. And now this is the bone. I wish we had a better model. We do not. I'll show you on the skull. This is the temporal bone. This is one of the sort of orangish colored. In classic anatomy, it's divided into 4 sections. Okay, there's the auditory section, which is around the distinctive landmark, the acoustic or meatus or external auditory meatus. And again, it's a meatus is a tunnel. You're going to see an inside and outside. So we have different areas. You have like the temporal area. This large bony prominence you can feel behind your ear is called the mastoid. It's a sinus. There's a lot of hollow in the bone. It's like a resonating chamber for hearing. So it amplifies what I'm saying to you. And that's why when you have a cold and it gets back there, sometimes it's harder to hear as well as it's harder to speak. So the mastoid, people get in trouble. Diabetics get infections, and when they go back there, we knew somebody, years ago, she had, hopefully a better treatment now, she had to have a mastoidectomy. She's a diabetic young girl. And here's the meatus. And so the points that are noteworthy on this are, these are called processes of projection of bone. You have the mastoid process, you have the meatus itself. This is the styloid process because it looks like an old stylus, what they used to do, script on tablets and things like that. The reality is, it looks like a sharp point. It isn't. It is muscles. It's called the sternocleidomastoid. Is a muscle that covers here. It's really nice muscle that goes like that. Anybody with a nice slender neck will be able to see it, appreciate it. Here's the mastoid. Deep to that are branches of that and other muscles. It is a source. The styloid is a source of attachment that is formed from the pull of muscles. Your tongue and swallowing. There's a styloglossus to your tongue. There's a stylohyoid to your hyoid bone. So it's an internal structure that is formed because there's multiple muscles attached. So we can't feel it. It's not like I can feel that sharp spike that's in there. And lastly, we call this the zygomatic process. We often name processes not from where they're coming, but from where they're going. It's going to the zygomatic bone. Other model that we have here, you can see it's not very big. That's the zygomatic bone on the side. That's your true cheek. This part of the organ. So interestingly, and again, this is more advanced. This little piece, even though it's not small, it's called the temporal process of the zygomatic bone. And that is the zygomatic process of the temporal. Classic anatomy. For our purposes, just have to know it's the zygomatic process of the spine. The 2 of them together form this, which most of us say is your cheekbones, called the zygomatic. It's very powerful, big muscle that allows you to chew, one of the 2. It goes from here to your jaw, it's called the masseter. And the temporalis muscle is sort of this neat, subtle indentation on the temporal bone, goes under that area. It attaches to thyroid fluid, according to the process of neuromolecular. There are 4 major muscles. We'll learn about the muscles in why I'm telling it to you was a specific nerve that goes to these nerves. And it's a branch of one of the cranial nerves, the biggest one. I will say it to you now. Whenever you figure this out, you guys are not newbies. Whenever a professor, instructor, teacher has a special interest, there's inevitably, we're going to make a point to answer questions. Their research. My wife has a terrible disease, thankfully it's controlled, called trigeminal neuralgia. It involves the branches of that particular nerve. And it's one of those. It's unknown the cause and very, very limited treatment, unfortunately. So you hear more about it in the future. Not today. That's when we do the cranial nerve talk. So that's that portion of it. Now let's see if we can isolate it. The temporalis is from here, goes to there, underneath that zygomatic arch. The masseter is kind of like from here, from that zygomatic arch down here to the angle of the jaw or mandible. You show it here, you're showing it a little bit internally, but not a lot to tell. Here, they call this the temporis portion. So you're going to see there is an internal acoustic meatus. Remember, a meatus is a tunnel. You have to imagine this is a point. Nothing comes out of that, but that's an input for the 8th cranial nerve that governs your hearing and your balance. We used to call it the acoustic nerve. You will come to know it is known as the vestibulocochlear nerve. That's here. And where the hits are just coming. So there's the occipital bone, big hole. Again, occipital condyles, those ones I pointed out. First vertebrae, hypoglossal canal. Can't miss it, and a whole bunch of other stuff. The ligamentum nuchae. We'll look at it when we look at muscles. There's similar to the muscles in your abdomen, where your abdominal muscles, which create the illusion of the six-pack, okay, similar to the bottom of your foot, we have a thing called the plantar fascia, like a bowstring across the bottom of your foot, helping to maintain the arch. You have the ligamentum nuchae is an area where the trapezius and other muscles attach to. A lot of times they may attach to bones, but a lot of times they have this thick, heavy, dense, soft tissue. If you're in the butcher industry, they call it silver skin. It's big, heavy, and thick, and if you cook it, you got to get it off before you cook it. It's not going to work. So you'll see here's the occipital bone, there's the condyles, okay, there's the canals, all there, all good, ready to go. Not a whole lot else there. You can see in this orangish color is the temporal bone. Adjacent to it, you can see the jugular foramen. And just the anterior of it, but you can see it's all in the orange bone, is the carotid canal. And so that, again, this one has stuff. You see other cranial nerves going through it. This does not. Okay, this just has that. And so you're going to see another couple of, bless you, another important part that's right here. And the reason I'm pointing out all of these to you is because there were cranial nerves. They're making their way out. So if we go back and look at this, you get a little ball. Happening, if you go between the stylus, stellar process, and the mastoid process, a little opening, I stick it into. Place it down and stick it into. It's called the stylomastoid foramen. It's tiny. When you take the book and look at it, you see that little opening between the mastoid process and the styloid process. That's where the nerve, called the facial nerve, the motor nerve that allows you to speak, do facial expression, smile. That goes through there, right in proximity to temporomandibular. So we sometimes see people with TMJ having problems with moving the face. It's a very interesting condition to look at again, which is called Bell's palsy. You've heard the term before? No? Oh, you believe me, you'll know somebody like that. And a lot of times we don't understand why. When we do the cranial nerves, I'll give you some insight into that. Fortunately, it's mostly transient. It can be permanent, and it's very, very common. Very, very common. And I thought from years of experience, even though it was the area that I treated, when you see something, even if it's 2, 3, 4 times a year, that's common. Okay? That's, that means you're as likely to see it as anything else. You always keep it at that. Some of these things you see once or twice in a career, depending on your area of expertise. And those are, you see unusual things at unusual times, and not frequent. So that was the other part that I was just looking at for you, and I'll see if there's anything else. You have stylomastoid. Here's the meatus external. On this side would be internal. It's a little hard to see. Show it to you. Again, these plastic models are a little bit better. So like putting my face in there. Even though it doesn't go through and there's the external. So you're there. This is the part of the bone where the hearing balance happens. It's very small. But you're talking about a cochlea, really different side of the skull. And so that's the meatus. You can see the jugular foramen, stylomastoid. There's a severe amount of anatomy. That's the point I'm trying to make. That is by no means the most. They actually have a decent one of these. I'll endeavor to show it to you. I think. Yeah, I can show it to you. So we're going to look at a couple of these in a second. Temporal bones, zygomatic process, zygomatic arch. Ooh, mandibular fossa. Huh. Right here. Sort of sticks in here. So that area here, covered in cartilage, very close to that between here's the stylomastoid ring of the interior styloid process. See, the way it is. That's a fossa, covering cartilage. So that is fossa, the temporal bone, and then you're going to have a mandibular condyle. Typically, again, condyle means covered in cartilage. This fossa is cartilage as cartilage. The only three will be very interesting for the glue, not just up and down, but side to side. That's the unique reason why. So glad I didn't forget that. Deep inside, I'm going to skip the sphenoid bone in the order that it's coming. We're going to look at that sort of a rig. If you go through all these skulls, we have a fair amount. The plastic ones, and even the real ones, a lot of them will have some prominence, some more so than others. You can see the little outline here, which outlines that part of the bone. That's called the ethnic bone. So whenever you hear, like me watching martial arts movies, when you hear about that karate or martial arts movie, you push up and goes, oh, it's true. Okay, that's the piece of bone. Okay. And that's part of the ethmoid bone. You can see that it's called the crista galli. Crista, new word, Gal. And that's what attaches to that, like the linings called the meninges or meninges, known as the dura. Think as the wall is attached to it. What happens if you disrupt that, you're going to basically knife that little piece perfectly. So that's where some of the anatomy comes in a unique way. Here you can see all the things I talked about. Carotid. You see they attribute to jugular foramen, though I think there's an occipital contribution. We'll get the foramen lacerum is really not a foramen at all. It's filled with cartilage, don't care. So here you can see it a little bit better with all that we looked at before. We're not looking at that. That's the interesting sphenoid. That by far the way is most complex of all the bones. Mastoid has air cells, mastoiditis. Coming back to sphenoid because it's a pain in the neck. Ethmoid. Considered the deepest bone. prepared by, and it's formed by, the best way to show it is schematically. It is so small. Turn the light on even more. It's so small. I mean, this doesn't really do it justice. Ours would be a little bit better. But if we look at it from this way, this would be the crystal galley. I'll tell you about these, and this is just schematically, it looks a bit like that. What I will do, since we don't have a good one, and the same is true for other of these, I use this. So maybe it's better to start here. Effectively, schematically, it looks like this. Crucible. So that's where the crystal galley comes from. Perpendicular to that on either side, these are called cribiform plates. Okay. This goes straight down. This is the upper portion of the bony nasal septum. Most of your nose is hard, as I can feel. If you go deep to it, the bony septum has two bones. They kind of look a little like that. So if this is superior and this is inferior, the bottom one is called the vomer. The lower portion, your nasal cavity is involved below in here. This is that perpendicular plate. We're just drawing it two-dimensional. On either side, the cribiform plate has tiny openings in it, all over, because it's quite large, called the cribiform foramina. Multiple foramina singular, foraminas plural. What happens through here, what sits on top of here, are what are called the nasal bulbs. That's how you smell. The bulb is a ganglion, meaning it's a confluence of nerve endings. Sensory nerves come in, and they all form together, and then the rest of the nerve for smell goes directly into your in the whole portion of the brain, just below the frontal lobe. So these bulbs and with the sensors go through the foramina. These are your true olfactory nerves. So you're smelling with those, and the nerve endings are distributed through this large amount of bone with lateral masses, lateral on either side. They give surface area to your nose. Shows you the picture of the dog. Yes. This is a nose. You wonder why dogs have senses of smell. This bad boy can smell. I mean, I could hide something I have to eat, a tiny amount, and all of a sudden, out of nowhere, I got company. It's the only thing he does reliably well. Smell. Hello, hello. I'm losing you. That's a nose. And if you don't like that, that's a nose. Not done yet. That's really a nose. You're taking courtesy of Camp Bow Wow. I believe that nose was used for inappropriate sniffing. As much as I'm going to... He's going to Blank Sniffers Anonymous. He's getting treated. But it's a concern. We try to with the cat, just cat. So if you wonder why animals have a good sense of smell, there's more surface area. Ours isn't bad. Thank you, Lincoln. There'll be a little something in your bowl tonight. I'm using his image. He gets NIL for this. Except he gets it in biscuits. Thank you, young man. He's a camp out. I won't even imagine the cat would probably want money. He's like that. But where we are. Okay, back to this. Stop doing that. Those are the parts of the anatomy that are there. It's very hard to determine. This is you're better. I just print the image and I'll have arrows and you got to label it. How's that? Where do you know? All I got to do is study it. I'll even give you a list, no extra charge, of what images I'm going to use. You can't ask for more than that. You will try, but you can't ask for more than that. Be happy. I'm in a better mood than I should be after some unfortunate play on the gridiron. Which unfortunately brings us to this. This is the sphenoid bone. They're in pink. Not the sutural bones. We're going to go back. Sphenoid bone, you have different angles to look at it. It is not easy. We start with the skull again. Got it. Hold on. So the sphenoid bone, taken out, looks like this. So this way, and you have to almost hold one, and the big enough so you can really identify it. It has, you look at it from different areas. This is looking at it. You look at it two different ways. This is looking at it, this is the anterior aspect. You have, and this is the superior aspect. It has small wings we call lesser wings, and large wings here and here that are greater wings. When the wings come together, you have, I pointed it out to you before because you can see it in every single skull. This gash is called the superior orbital fissure. The one that appears below it, you might remember me telling you before, the one that goes below is called the inferior orbital fissure. It's again, it's an artifact of the skull cartilage. It just shows up when we boil the bones. This has 4 different nerves. 3 cranial nerves is part of that big 5th cranial nerve. With my wife's condition, I'm going to tell you about inferior orbital fissure. So this is obviously part of the orbit. That ethmoid bone, by the way, we did before, that's part of the orbit, way in the back. Here. Also, in that area, so superior, you have the lesser wings and the greater wings, they're confluences of the fissure. If you go inside, you will see a tiny opening. If you look at it this way, going in, imagine going in the eyeball this way. Your optic nerve comes in at an angle like that. Now, I'm fortunate to have one of these, and I do. I've probably done this book, I don't know, 6,000 miles. No, it's okay. They crisscross. Imagine that's the nerve for your vision, the optic nerve. Crisscross, we call that the optic bias. It's a very important area. Sitting in that little, anytime you see a bony area, it's like a little chamber, that's called the cell tertium. And on top of that, or in the same area, is where we put the circle of Willis. Proper name, W-I-L-L-I-S. That's where the blood supplies of the traffic circle. What they erroneously call roundabouts. We in New Jersey invented the traffic circle. Okay, and that's where all the blood supply down to the traffic circle. But in Philadelphia, we've got the Route 70 to the traffic circle. What are you talking about? So, and that has a circle of Willis. That's a generous blood supply that can go to multiple areas of your brain. We will cover that as well. So you have that. And so what is that opening? That is the optic canal. It differs from superior orbital fissure because that goes straight down. So if you see a marker there, you will. You'll know which is which. Optic canal, superior orbital fissure. We're in the sphenoid bone is yes, moving on. So if you look at it from top down, you see a marker there with a little marker. That has That's the cell turcica. You can see that as well. And that leaves us with 3 openings. You see those 3 openings here? They are foramina. Again, the one that you see here, the lacerum, is an artifact filled with cartilage. One goes forward. Retinal spheroidal fissure is round, called the foramen rotundus. You can stick it through here. That's another one of those branches that the cranial. Yes, we have the foramen ovale, the largest. That's yet another one of those branches. That's the one that you chew. The 5th cranial nerve. And then you have a tiny one off to the side. It's like what they call spinous. It's like a little opening, not for a nerve, for a blood vessel. Tell you what blood vessel is, what's relevant to us. We do blood vessels over again. It's for the middle inch. It goes through the area. That's one of the big problems with somebody's side of their head. It's not just concussion. Trauma is in the right place. You can rupture that vessel. And then you get, that's where you get some door or something like that. That's the big word. Football games is like Metro in the city. We didn't see it. Well, they didn't appreciate it, but players were just so much more. I mean, you go back and look at Minnesota's, when they had like 4 Super Bowls, didn't win any of them. They had the purple people eaters. Nobody was that big. I mean, if you see Alan Page today, I mean, he was from Notre Dame. Maybe he played 6'4", 250. Carl Eller, 6'3", 250. Jim Marshall just died, 6'2", 240. So, one of the biggest guys. The Giants had a big line in the early days of the Giants when they were losing the Packers. And Rosie Greer, very famous, went on to do a lot of TV. He was the biggest guy. He was like 6'5", 275. He was a monster. And he did a lot of TV. He's actually, when Bobby Kennedy was assassinated, he was in a cadre of people who were protecting him, not expecting somebody to have a gun and shoot him in there. So we were actually, he was the one who got Sirhan B. Sirhan, tackled him. That was enormous then. Today, that's, you have 6'5", 300-pound guys that are all muscle and run like a deer. And you wonder why the injuries are so, but this is what people pay to see. Oh. One more thing. Pterygoid processes. So, you don't see these. You only see the advantage of looking at it here. So I'm showing it to you what it looks like if we would dissect the bone out. But you can't. They're all stable. And this is what we call cornerstone bones. All cranial bones. Okay. Questions. You're going to see the same thing is true when we get to the maxillary bone very shortly. All cranial bones interact with the cornerstone. The thing is, if you see these guys with ridges under here that are incorporated here and here, those are what they call pterygoid plates. You get to the muscles here, there's a medial, internal plate, and a lateral process plate. And basically, there are 2 muscles that go to the interior portion. See it right here, inside here. So they allow you to protrude, retract, go side to side. These are the little cow muscles. But they were, you would have that great shot of it would be very, very distinctive. So those are the pterygoid plates. Pterygoid because they look like, in those days we call pteranodons, pterodactyls. Or dinosaurs. It's all right. I have a grandson coming up who's 5. I'm sure we'll be all dinosaurs all the time. But I'm not explaining he wants to know about the immune system. But he got his first Taekwondo belt. And we are still surprised that the kindergarten teacher has not resigned or run out of the building screaming. So that's all. There you are. Canal, spiral fissure, rotundum, ovalca. I know all these. Spinosum. Okay. Well, I use the pictures. I use that model. I use the skulls. There'll be markers all over the place. You'll be able to see it. It takes a while for me to set this up. I do have time. So, I mean, we may or may not, with that, if it's doing the 29th, we may or may not start that at 3. It might be a little bit later, but that is what we will do on that day. So once you're done with that, see it. Ethmoid is the deepest. We covered that are there. And those are those bones. We'll do in a second. The rest, now we get to the facial bones, the sutural bones, insignificant. Okay. Again, these are a little bit easier. There's no anatomy save one, and that's the mandible, the only one that moves. Again, it's actually 2 bones, but when you're born, it has fused. So in anatomical convention, if the 2 portions of the bone have not fused together, then it's considered 2 bones. If it has fused, it's 1. Very straightforward. Look at it a little bit last time. What you have here, nothing really special under the sun. Condyles, they're placed into temporomandibular joint, fossa on temporal bone. So temporomandibular, TMJ, dysfunction, mandibular notch. Choroid process, where that temporalis muscle that pulls on. This is called, what's holding here is called the body. These are called the wings. See another name coming up for that. You have, again, one significant foramen, you can see it here. See it there on the inside. That's that mandibular foramen, one where I think my wife had that done today with this implant she had put in. One injection in. So that's what we're going to go into a field that involves local anesthetics, all about the anatomy. It allows you to use 1 or 2 shots where you might not want to use 3 or 4 times. So nobody knows better than dentists. Folks like me, if you're doing a lot of hand and foot surgery, lends itself very, very well. Right there, so that's it, and they call this the angle of the jaw, body, wings. That's the anatomy. Everything else is name that bone. You can see it here. Angle, coronoid process, condyles would be fine, the notch, body. I'm not worried about the symphysis or the mental foramina. That's a little opening there for nerves and blood vessel anteriorly, not a big deal. Right there. The name that we use for the wing, and you'll see this again, is a ramus. The plural is rami. You'll also see this in the pelvic bones, in the pubic bones, and in the pubis and the ischium has rami as well. Wings work, rami work, I don't care. The angle, why is the angle? It's a landmark. The field is called surface anatomy. It may have changed, but did anybody do that course that they were doing up in the eye center, which would be out in we were taught, maybe it's different. You went to field for circulation, you went to the angle of the jaw and felt around there, and that's where you're looking at. That's what it's important. See, surface anatomy is all about that. And very, very useful. This mental foramen is pretty insignificant. Mandibular, to me, is a lot more important. It's got it. Everything else is bones. So, I mean, I can give you a look-see on these pretty easily. You see this? In white, nasal bones. Nasal bones are not, the nasal bones are not, believe it or not, as you can see, part of the organ. It's the only part, it's the bridge of your nose, you don't call it that. You hear about broken nose, inevitably that's the part that's wrong. Purely common injury. And it's sort of this color here, that's inside, that's the lacrimal bone, It's where your tear duct is. You can feel that little rumble, that little bump that's in there. That's part of the organ. And I showed you the zygomatic bones, true cheekbones. That's part of the organ. Zygomatic bones, lacrimal bones, the bone that they're all attached to, the mandible, big part of the maxillary bones. Okay, one on either side. What's interesting about the maxillary bones is this. A lot of the shows you watch on TV, you're seeing advertisements for some of the medical programs in other countries, less fortunate, dealing with what? So, this is your hard palate. What happens when children? What do you call it? Real organized. Cleft palate. A cleft palate doesn't have to be visible. Most of those cases are pretty severe that we show you on TV before they happen. And it's called, there's a real human money in cleft lip. If you have a cleft lip, you got a cleft palate. If you don't have a cleft lip, it doesn't mean you have a cleft palate. Twofold problem with cleft palate. Biggest problem, suction. Can't seal for the baby nurse. Second biggest problem, that's an opening. This is your bony palate. If you look at the other color behind it, that's the other bone. Remember, lacrimal, zygomatic, maxillary. These are called the palatine bones, part of the palate. They're L-shaped, one L and reverse L. There are two of them. We form that area. That little peak up here is actually way in the back of the foundation. So they're all paired. Think about the size of those here, so you can get a lot out of this. There's not a whole lot. The vomer is that plow-shaped bone, and technically speaking, it's not even in here. See those guys in yellow? They're called turbinates or inferior conchae. They again are bony areas with a lot of surface area. I think anatomy is just that somebody had fun how to write papers. Technically, it's separate from the anatomy. So I'm sure it's legally speaking. So I'm trying to give you the classic anatomy, but I don't necessarily have the law of the classic anatomy. And then it's the facial work. Almost done. So try to get through the rest of this. 4 days of pristine quiet, rejuvenated. It's our anniversary. Are we allowed to go away? Good Lord. Maxillary bone, sinus. Nothing else. I mean, I'm trying to keep it fairly simple. There's not a lot there. The vomer, that's the vomer down here. Here's a conchae. Inferior parts of the nasal bone. The vomer would be over here. This neck of the bone. Here it is. Vomer here. Perpendicular nasal bone here. Perpendicular plate here. Nasal here. Vomer here. Conchae up. The only bone that is not part of, and it's really very discussed in muscle, this is the hyoid bone. Hyoid bone is the only bone that doesn't have contact with the bone. We're going to talk about movement as contact. It's actually formed by a series of muscles, these organ anchored bones that help you swallow. So and clinically, it's a very important bone. So when we see a fractured hyoid rather, that's stroke suggestion, so it's forensically relevant. So a lot of that stuff is very interesting. When shows like CSI came out, people got really interested. A lot of universities tried to staff the bone. Duquesne had the advantage because they had, maybe arguably one of the two most famous forensic pathologists in the country, the late Dr. Cyril Weck. And he basically drove that for them to develop their forensic science area. I mean, I think it's named after him. And again, it was in his lab, his associate did all the concussion stuff. So Weck was kind of an interesting guy, very active in politics. I knew him to say hello because when I was on staff at St. Francis Central, he was the chief. He was our president of our medical staff. I mean, he was there. From the point of he became famous even during the Kennedy assassination. It gives you an idea of the timing when he was a very, very young doctor. So, only bone that does not articulate directly, anchored by ligament, tongue, side of attached to muscle, swallowing speech. Pretty straightforward. There it is. You see the location. It's hard to feel. What the orbits. Remember, know the names of the bones that are there. Nothing else to say about that. Don't worry about the nasal cavity. We'll talk about that. Respiratory. Sinuses we talk about in respiratory. The ones we call paranasal, just for clarity, maxillary, frontal, ethmoid, sphenoid. Think of where if you have a sinus ache. I'm congested now. I can feel it. My ears get clogged. So if my voice changes, because I'm trying to make myself loud enough that I can hear me. See you later. Have fun. Are you hanging in? So nobody's giving up the ghost yet. Good for you. God, I love when a class comes together. 2 football games tonight. Hey. My wife loves watching the golf. She's a big Scotty Scheffler fan, which means she gets to see winning a lot. I keep telling he's married. He's got a beautiful young wife. He's got a kid. Stay away. Try to think where we're going. I was going to say, you should hear what she calls me. Okay, vertebral column. Skull to pelvis, spine, spinal column. Again, remember I showed you the spinous, we're going to show you the vertebrae now. All the stuff it does. This is 26 irregular bones. Here's how they do the count. The count's important, and when we get to nerves, spinal nerves, the count is similar but not identical. The length varies, it's not a big deal, bless you. Cervical, 7 vertebrae. 2 of them are immediately identifiable, they're unique. They act as a universal joint. I commented on one before, C1 or atlas. That accounts for your head nodding side to side. Okay, when we talk about rotation, C2, which is called the axis. And remember, things rotate on their axis. So if you're thinking no, that motion, that's the atlas and axis are really 2 bones that we probably should consider as one. And they form this sort of, with lack of a better expression, almost like a universal joint that can go in multiple directions for your head. Very significant. That's the first 2. There are 5 other vertebrae that typically get increasingly larger. The spinous process is most prominent on C7, so it acts as a bit of a landmark down here. And again, these are, depending on what field you're going into in a clinical field, these are important. They're all the time. The nursing students, to give injections, you've got to know those landmarks because they make little triangles so they're not sticking an injection somewhere where it could do some damage. Like when you get a shot in the rear end, you don't get it in the gluteus maximus routinely because there's too much of a chance you could hit the sciatic nerve, which it covers. Use gluteus medius, more of a hip than a butt. All surface of it. So thoracic, 12 ribs, 12 vertebrae. Lumbar, low back, small of your back, if you want to remember it that way. Mine are more continuous than that. And then now, if you count as well as I do, that's 12, 7, that's 24. How many did they say there were? 26. The sacrum is a fusion of 4 or 5 vertebrae, but effectively it's one bone, as is the coccyx, your tailbone, which is a fusion of typically 2 or 3 that are there. So there's more than one. They're not nearly as important. These are curvatures. Think of when a baby is born. You think of the fetal position, baby is all curled up, its head's down like this, knees are up. It's a big C, okay? If you look at the posterior aspect, the back is convex, anteriorly it's concave. That is called your primary curvature, convex posteriorly, thoracic and sacral. You see cervical and lumbar are different. You feel back here, it is concave. If you go to lumbar, what we call the small of our back, it is concave posteriorly. Why does that happen? Bones and the rest of and surrounding structures adapt to the pressures. 3 to 6 months, what does the baby do? Begins to control its head. Somewhere between typically 12 to 15 months, surely by between 9 and 12 months, the baby starts to stand. 12 to 15 average, they ambulate. There's a lot of room on other stuff. Treated a whole lot of babies over my years. Okay? So those are your secondary curvatures. So that's what they're trying to point out. When we look at them, you have primary, which are the ones. So when you look at primary, we're looking at sacral and thoracic. Secondary, you're looking at cervical and lumbar. If you want to think large, think lumbar. There's a lot of ligaments. I don't go into all of them that are there. There is so much. It is so complex with so many structures. It is very difficult to access those. Over the years, and they have to do like fuse somebody's spine. Very, very difficult. Most of the time now, if it's cervical, they'll go anterior. It's a lot easier to retract the great vessels and your trachea that way, and do an anterior fusion than a posterior fusion. The scar happens to heal very well. It's tough to go in through the back. It just is. There's just a lot of thick stuff that's there. So I don't go into all that nomenclature. You can just see from the illustration what happens when the vertebrae sit one on top of the other. Effectively, I've got 2 that are lumbar, and I don't know that they're necessarily one on top of the other. See what they look like. The lumbar is just a classic vertebrae. They have head in between. That disc separates in such a way allows what that spacing does, it creates that opening and the spinal nerve exits the sides. And when that disc is messed up, damaged, slips, if you will, herniates, then that happens and you get some impingement on the nerve. That's when somebody has something like sciatica. Okay. So the disc is really part of the assembly. There's a lot of soft tissue. You see anatomically, the vertebrae all, and you're going to see the difference in cervical, have a body, spinous process, again, the big identifier in the back. So hold it like it would be an anatomical position. So that on either side, I'll turn it this way, transverse process. And then you have superior articular particular joint and inferior articular processes. And indeed, they have, as you can see, cartilage on them, bottom to the top. You can feel it even on these plastic models. And they kind of, and that's where you get limited amount of motion. So that's where you actually think of how much, how versatile you twist and turn, whether you work out with your playing sport, all that type of thing, how swing, how much power you generate. All those things, so it's a little bit of motion at multiple joints that allows this wide and smooth of motion that occurs. So that's the general anatomy. I'll show you a couple others easier to see. Again, you can see all the ligaments, the intervertebral discs. This is the remnant. Go back to your zoo. Remember the 3 things a vertebrate has, right? Dorsal hollow nerve cord, pharyngeal pouches, right? That's our middle ear. And what else? I'm wagering everybody here passed zoo. Okay, maybe not. Noto cord. It's got a soft center that's a gel. That's the remnant of the noto cord. Called the nucleus pulposus. Just what it says, the pulpy nucleus. Squishy. Compression. And it has annulus, means circular. Fibrosis tells you it's thick and firm. Outer collar, collagen, and fibrocartilage. This is one of the fibrocartilages, just like the menisci in the knee. Intervertebral discs are like that. Pubic symphysis has a disc, it's like that. Limited expansion of the pulposus when compressed. It's the pulposus that herniates through and creates pressure on nerves, wherever it might be, whether it's neck. Typically, it's the areas that move the most, the neck and the lumbar area, by far and away. Thoracic, you don't see as much. So voila, here you can see it. Here's this the herniation of the pulposus through a gap, a weakening in the annulus fibrosus. Here are the spinal nerves going through this little canal, okay? The big canal is the vertebral canal. That's for the spinal cord. The between the vertebral canals going side to side, they're for the spinal nerves. And you can see, and depending on where it's pinched, it might be needles and pins, it could be sharp pain, it could be numbness, a lot of different things. I took, what happened to me? I bulged a disc 2013, 12 years ago. It was in August 2013. Because my wife and her sister were up at the Westmoreland Fair showing stuff. They had like a booth. And all of a sudden, I bent over, and the next thing, I wasn't even up there, I was at home. Searing pain, total numbness I still have numbness here. Doesn't mean I have perfectly good function, but if I get on my hands and knees, I don't have any feeling of that. So that nerve was shot. And thankfully, it's responded tomorrow. That means every 2 weeks, getting myself adjusted. We old people. Moving along. So here you can see all those areas that are there. That's just effectively an MRI with contrast. You can see where the disc is herniated. Look what it's done. You can see the impingement along that area. These are just fluid levels. When you learn about MRIs, there's type 1s, and there's phase 1 and phase 2 things they use to show fluid that's in there. Prolapse disc, wherever you want to cause it, blah, 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 blah. I would never contemplate surgery. I have now done with all surgical interventions, unless somebody tells me I have to have it to live. No more. Now, there's a lot of curvature. Some of these are congenital, some are not. My late brother-in-law, former brother-in-law, was born with scoliosis. He had, unfortunately, and you'll see the illustration, that's when they have you bend over, and as I showed you before, you can feel those spine. All you do is, the doctor has you bend over at the waist, runs their finger down. If it's an S-curve, there's scoliosis. He had to be, in those days, in whatever procedure they did. If they put rods in there, I don't know. It's a long time ago. He was 78 when he died a couple of weeks ago, unfortunately. And he had to be in a body cast for like 6 months. That was what they did back then. And we're talking 65 years ago. I'll tell you around that time. So you see kyphosis, abnormal dorsal thoracic curvature. And so the most common people you see this with are older people from compression fractures, which we're going to go over on Wednesday. These are fractures in the vertebrae, and the head's heavy, and it can't be supported. So it appears that they have a hunchback. This is not the the author's name is on the tip of my tongue, but I'll get there. Victor Hugo. I'm very disappointed. If I can't remember everything, I'm upset. But I forgot to get something printed for my wife, so she was unhappy with me earlier. Hunchback of Notre Dame, that was someone who was born with a massive deformity, irregularity, as opposed to the hunchback you see there. Lordosis, you might see with somebody who's pregnant. Scoliosis, elderly person, that's artificial. That's because that's a compression fracture. Lordosis clearly related to pregnancy. Though sometimes these occur with birth defects, and again, it's more of a gross deformity, gross visible deformity, and the lordosis the same way. That's a pretty severe scoliosis that we see. So this is the commonality. You'll see in a second. Rather than me read that, look here. An illustration you will see on the practice. Bless you. So you're there. You can hold on. You can do this. Again, my teaching philosophy, if I'm not enthusiastic, why would you be? Think about it. Oh, God. Body. So anterior is the body, posterior, spinous, transverse processes, vertebral. The shape of the foramen also gives you a clue, but I'll show you the easy way. This is called the lamina, the area between the spine, that flat piece between the spinous process and the transverse process. It's circled wrong. The place between the body and the spinous processes down here is called the pedicle. When you used to do surgery, you did a laminectomy and fusion. You had to go in and chop out this piece of bone and access the spinal cord that way and fuse. It was like a bone graft. That was the old way they used to do it. Everything now is a lot of microsurgery that's done. It's very sophisticated. Again, I would not be a big fan of it. And again, the superior and inferior articular processes. So as we look individually, C1 through C7. Yeah. Looks like a big circle. It's the only one that doesn't have a bottom. So it sits, imagine here we are, sitting on top of it like so. Yeah, it's holding up the globe. I never got it right set up. This is called the axis, or C2. C1, C2, they sit together, they're teeth. So basically, you can rotate. There's a little joint, see a little plastic here, a little area for the joint that's there. It's cartilage, and it's called pivoting. One of two in your body. That allows you to go from side to side, but they are function effectively. We know they're cervical for another reason, and these are called, these openings on the side aren't something so you can wire together. They're called transverse foramen. Look over on the other back there. They get my steps. Oriented. You can see not only the spinal cord and the spinal nerves, but the red. That's a special circulation that's going to your brain. Your main circulation is the carotid arteries. These are called the vertebral arteries. They're like your back. You have 4 arteries that can service your brain, and that circle I was telling you about, as long as you have a couple of them intact, your brain gets fed. That's why when someone has a blockage in the carotid, it's not like they're not going to keel over and die ordinarily. You have some opportunities to do procedures to be able to remedy that while they still have circulation. Just to give you an idea, so that's the key. All of these have what's called the transverse foramen. So here are the two I showed you before. Here's another one. Real bone, kind of beat up. Same deal. Yeah, on either side, the little body, it has a disproportionately wide vertebral canal. The spinal cord is widest up at the top, it gets narrow. It goes to a tip, to a point. You're going to learn it's almost like a conical end. The column is called the column medullaris, medullary column. So all of those, not only are they small, they have vertebral canal. Best way to remember any of these, anything that is thoracic, is the spine goes dramatically down. The spinous process is always pointing inferiorly to hold the base of the body. But the lumbar are large and they have like a hatchet shape prior to the okay, spinous process. You can see, and then there's subtle changes, but I think that's the easiest way to remember it. Again, if you're doing medical school anatomy, graduate anatomy, they would look at the position of the superior and inferior articular facets, etc. That's part of it. You can read through that. Again, look at the size of the openings comparatively, because the spinal cord is getting more and more. This one's quite wide and triangular, more circular, and now even though it's triangular, quite a bit smaller. The transverse foramina are there. So you can begin to see, there's the spinous process, you can see the declination. Sometimes these are because they're bifid, they're forked. We have a few like that. That's another little tell. So it's that's where I got a telling sign. Is that a reference that you would understand? Anybody play poker? I mean, like competitive poker? Okay. I'm on the phone, Junior. It is a tell is like a poker player looking to see if somebody's bluffing. Maybe they do this or they pull their ear. That's a tell. My eldest was the rep for the Cats Business School back in like 07. And he won the tournament locally, regionally, and they sent him to Vegas. I mean, I think he paid his way to Vegas. He was chip leader, I think, as they ended in the final table. He ended up fourth. Made a few bucks. He's a father of two. He doesn't gamble as much. He went from driving a Z4 to driving a truck. It's classic. My boys both went from driving sporty cars to trucks. Atlas, C1, no body or spinous process, as you know. Just basically there's big arches and what we call the lateral masses carry the skull, just like you had before, the lateral masses where you see the facets. Also on the underneath side, the axis is, they think this is the missing body. The little part that sticks up that allows it to rotate is called the dens, okay? DEN, some people call it the odontoid process because it looks like a tooth. Dens are dental. You're getting there, it's okay. Oh, you're doing great. I didn't even take a break. I'm 74. I should be tired. I should be taking a nap in the middle of this. I should be the one running to the bathroom. I'm the one who had prostate surgery. I haven't figured that out yet. It's all right. I'm so different when I get home. I plop down. I'm immobile. Even the dog looks at me and goes, really, could you let me out? Why don't you let yourself out? Here it is. See the illustration. There you can see that bifid process. There. Not a whole lot to say about thoracics. If you look closely, okay, in a real thoracic vertebrate, they have little facets on the body. You can't see this on transverse process. That's where ribs happen. The wrong rib, it's kind of like this. We call them demi-facets, like facets. I understand it still moves, but not all. But if you can't accumulate all those, you get a fair amount of movement. So I have no idea if this is the way the ribs are. So that's where you have to, classic anatomy, you have ribs, you have a head, you have other stuff. I don't quiz them. Try to give you an idea what it's like. Yeah. And small the back, most of the stress. Short and thick, big, hatchet shaped, triangular opening. The orientation is not pushed looking backwards at that angle. So it's really it's all, when you get lower, it's about stability. As you head to the lower extremity, think stability. As you're in the upper extremity, you think mobility. That is there. Nothing a lot to see about it, I don't think. The sacrum, there's a lot of anatomy, and I don't do any of it. Sacrum. What is it called? Sacrum. I'm sure there's one in here that isn't up extraordinarily. So here it is. The sacrum, where it attaches. These are called the most notable anatomy things where it attaches to the hip. It looks like a ear or an auricular surface. It's rough, so it doesn't move a lot. It's not designed to move at all. And it's able to attach here. This guy. That's your sacroiliac. Iliac crest, the auricular process, or auricular surface. There are two surfaces. They really don't cover the cartilage, which means they're not designed to move. They fuse together so the foramina don't go to the side, spinal nerves, they go out in front. That's the interesting part. You're going to see where the cord ends here. Spinal nerves still keep coming out. So they're not really, they have a lot more mobility, and when you take them out and look at the spinal cord itself, you can almost tease it out wide. It's like a horse's tail. There's a little bit of lattice here. There's not a whole lot to say from this shape. And the coccyx vestigial, have it on this model. Your tailbone, who cares? The biggest problem with that is sometimes you break it. And I mean, it hurts for a while, but it's really, the worst case scenario is somebody would remove it. It wouldn't be that, it's really nothing is there. It's vital whatsoever. The crest that you can see is like a fusion of all the spinous processes. It's just really not much to say. And then you have the sternum. Now the sternum, I use the model, and the ribs you saw before. The sternum is extraordinarily important. You don't see them with the cartilage, so really the best way to demonstrate it, which we'll talk about it, this guy. The fusion of three bones, the smallest of which, most inferior, which really doesn't fuse to about more. So the sternum, or breastbone, consists of the manubrium, the body, and the xiphoid. Unless they change the CPR, I would always put palpate the xiphoid, two-finger breaths, starting for compressions. You've got to make sure you're doing compression on the body. You're not doing compressions on the body. So palpate this, two-finger breaths, feel the hand there. Once they change the rules of CPR, since I lived 3 episodes you guys can talk about it. There's a little notch there. That's called the nuclear notch or sternal notch. That's a guy, that's in your anatomical landmark. You have to trace it. Your midline. Great vessels, broad, jugular vein. Much less trouble here. The only thing you're going to hit is trachea, pre-sternum, tissue side. There's basically fibers there between cartilage rings, or C-shaped, like this. Close anteriorly, and do the cut, and insert that area. We're not telling you to do that. Side. And these, both costal, C-O-S-T-A-L, cartilages, they will give a little bit. There's a certain amount of motion. Again, these transition become bony with aging. That's why elderly folks, particularly those who are worried or have compromised pulmonary disease, makes pneumonia big. So eating and smoke for 4 years because it's part of our stop. Again, that's it. I was telling, I think that was my daughter, being pretty angry, thinking I wasn't going to be there for her wedding. So she had to get married 2 times to the same guy. One in Cancun because everybody could come. They had it again in her house up in Indianola. I got to give her away twice, but she keeps coming back. So everything you have to know about that. Jugular notch, mandibular, it's a notch. A lot of this may be, depending on your field of endeavor, surface anatomy, not a whole lot else to say. You get mid-sternum because you can break off the xiphoid. You won't be getting compress. The whole idea in CPR is you want to be between the vertebral bodies and the sternal body. You compress the heart manually. That way, it's the mechanics, as it were. And you probably all know that. Lead us to the ribs. You'll see the illustration better than me pointing to it. There are 7 true ribs. What's meant by a true rib is it is directly attached to the sternum by way of a cartilage. False ribs, okay, are they have it slightly different. Well, I'll go with it. The false ribs are 8 through 10. They attach indirectly. They join a cartilage, which then joins the cartilage to the 7th rib that's going to sternum. And the floating ribs, 11 and 12, do not attach. You can see it on any skeleton. You'll see it any one of these skeletons. You see just 11 and 12, and you can see what it looks like here, anatomically. Here, 1, 2, 3, 4, 5, 6. Here's 7. Okay, going all the way here. 8, 9, and 10 all have come together as a cartilage, which joins sort of the undersurface of the cartilage for 7, and then into this lowest portion. Hence, they're false ribs. These float, 11 and 12. Again, this is more of the anatomy. I don't get excited about that. There you can see the attachment. That's what I mean. There's a little attachment on the body and a little attachment on the transverse process. You can identify heads and necks if you want to. I don't. Like that. There you can see these. Again, they're called demifacets because they're not really big. Demi would be like half, like a demitalis coffee. Look at that. Do a couple upper extremity things and let you go. Can you give me 20 minutes? I'm not seeing it. I'm not seeing any ascent. You have lovely teeth, though. I do too, but I can take mine out. I mean, when I go to the dentist, it's easy. I just leave them. You like your car? Are you going to wait for your car or are you going to leave it? Are you going to wait for your teeth or are you going to leave it? See, that was funny. A little gross. I'll buy that. You surely have a grandfather this old. Older? Maybe not. It's all right. I can take the hit. My best friend in the world, he goes, we wish each other happy birthday. I go, yeah, now you're as old as I am. He says, shut up, Lou. We're both old farts. But he could still have to go. Okay. First of all, the fancy name, and we had it. I don't know where it is. I don't know someplace where they were attached. The combination, without looking at the fever, the combination of this. So here you can basically say, look, shoulder blade would be here. This would be left. The combination of a clavicle, which is the strut. That's the only part that's attached to the axial skeleton. Attached here, sternoclavicular joint, attached to the sternum, just above that first rib. So as I showed you before, you can just turn around and start moving this. You can feel that joint. Sternoclavicular joint. So the clavicle is basically the strut. Again, it's refracture lower body, triple toe. A lot of people think. And the combination, not including the uterus, that not including the uterus is the pectoral vertebra, clavicle and scapula together. They are the two. There's not much to say with the clavicle. A lot of times you've got a small rib, flat rib, gentle curve. Okay. And the clavicle is much sturdier. Clavicle, there's not a lot to say about it. You really have a couple of ends that are associated with it. You have the end, you can feel the cartilage on it. That's the part that basically makes up that sternal leg. And then you have part that goes against the scapula. Get myself a scapula. Oh, here it is. So here's that wide end, sternal end, that's what you have to know. And there's another culminating tubercle. And this is the acromial end. The name of this joint is the acromio, that portion of the scapula. Clavicle, clavicular AC joint. You hear about a shoulder separation. So when you see it in school all the time, typically they go down. That who was the guy that was Worthy went down in the first one with Kelsey hit him, dislocated shoulder. Yeah, right there. Now I wasn't clear whether a dislocated shoulder was all that shoulder separation. Since they were saying dislocate, I assume he was short. Yeah, shoulder. Just for language they were using. That way there. That's the difference between a separation here. These are much more common. Dislocations are, as they become chronic, are not as difficult to treat. We look at that a little bit when we start talking about joints. It's based on the anatomy. So that's really so the clavicle, by definition, this apparatus, this very, very famous apparatus that we call it, this is the left. We can always see in the scapula, that's the socket for the head. It's not a particularly impressive socket. If you look at a hip, that's the socket. That's a socket. Mom said, show me a socket. The ball and socket joint, that's the socket. She shows you this, really the analogy they use all the textbook uses. It's like a T with golf balls. Again, mobility, stability. Upper extremity mobility, lower extremity stability. It's all about the anatomy. So this strut, there's nothing holding it there per se, it's just got muscles. It has a lot of mobility. This basically just anchors this. And there's nothing unlike what you see in screwed onto the sternum, there's nothing here but muscles. When we get into the muscles that are there, we'll talk about the rotator cuff. All those things. The rotator cuff is a series of 3 muscles in the back and 1 in the front that help to secure the head and fever into this particular joint. So we get a head and fever and joint. I'll show you. So you can see it here. There's not much to it. So let's first look at the scapula. I know you're tired of this. I'm tired of this. So again, anything that's important has stuff that's attached to it. So noteworthy, you have, since of the highest is called the acromial process. Below it is the coracoid process. That's where one of the heads of the big bicep brachii muscle, called short head attached. Creates a lot of force. This is called the glenoid fossa. Eventually that gets covered in cartilage and surrounded by a cartilage rib. Not unlike in this side of your knee. You have a name for it called the labrum. You hear about someone having a labral tear. You have one in the hip as well. The labrum just gets flipped, and it just deepens the socket. Even the socket is socket on the hip. So you have that. Then you have really, as the extension of the acromium in that whole process, we call this vastly, we call it the shoulder blade. Typically, it's just, see the name here, as they begin to describe it for us. Pectoral girdle, acromioclavicular, clavicle, sternal end, acromial end, nobody cares. Nobody cares about the conoid tubercle. The scapula. So you call it the spine of the scapula. That's the name that this author particularly uses it. Some people just use the term shoulder blade. I was just looking to see, remind myself what they said. So, and really the anatomy that you need to know is this. The difference between the acromium and the coracoid process. The glenoid, not worried about the notch, not worried about the borders. What this divides it, normally it's like this, kind of sits like this. So this is called the subscapular, below. The reason I'm making a point, it's a fossa. There's a big muscle that sits in there. Well, subscapularis, it's part of the rotator cuff. A lot of times we'll just take an area, subscapular, add IS or US, and voila. This, where you're at the spine, you have a fossa that's above it, supraspinous, and infraspinous. Supraspinatus muscle, infraspinatus muscle. So, and those are the three posterior muscles, two of the three posterior muscles, rather, that help to create the rotator cuff. The subscapularis is anterior. 3 in the back, 1 in the front. Most dislocations, as you will see anatomically, are anterior. They go anterior and inferior based on the anatomy and the overhang, which I'll show you next time. So all of that is part of that particular bone. You can see it here. This would give you an idea if it had that labrum, but not drawn to scale. Really not drawn to scale. Labral tears are a real problem. A lot of times they end up requiring surgery. This time of year, depending on the sport. If it's early in the season, they might do the surgery. If it's in baseball, you get a lot of pitchers get shoulder-related problems there. They'll try to wait it out, particularly if they're playoff bound. It's good to be a sportsaholic. In interest of preserving our relationship, I will stop here. There's not a lot left to do. Okay, we'll get done with the bones and you can all look at them. We'll have open lab to look at the bones next time after I finish the lower extremity in preparation for this practical. I also have to talk a little bit about joints, but I can do that in lecture as well. Okay, all good? Nice chatting. Have fun. My voice and I will never be the same.